Hello everyone and welcome to this lecture on orofacial pain. I'm Dr. Lahari here from the Department of Oral Medicine and Radiology. The learning outcomes would be to classify orofacial pain, summarize the methods of measurement of orofacial pain and disability, explain clinical features, diagnosis and management of facial neuralgias, describe in brief the clinical features and management of atypical odontalgia, vascular pain and burning mouth syndrome. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It is very important to understand that is pain is subjective. So, when we are discussing the characteristics of pain, there are two mnemonics which are useful in assessing or taking the history of a patient, and both of which are having similar components. It's either Socrates or Olcart's. Socrates stands for site, where is the pain or maximal site of the pain. Onset, when did the pain start? Was it sudden or gradual? Include if it was progressive or regressive. Character of pain, what is the pain like? Is it an ache? Is it stabbing, lancinating, or other examples of how the character was? Radiation, does the pain radiate elsewhere? Associations with the other signs and symptoms that could be associated with pain, for example, swelling. Time course, does the pain follow any pattern? Exacerbating or relieving factors and what causes the pain to change, and severity, how bad is the pain. So this also can be applied to the old cards, which is also very similar. There is onset, location, duration, character, aggravating and relieving factors, radiation, treatment received, and severity of swelling, both of which can be used. So these mnemonics help us to remember all the points that are required to be present in the HOPI of a patient who's come to us with pain. Some important terminology when we are looking at discussing pain. Analgesia is the absence of sense of pain without loss of consciousness. Anesthesia, on the other hand, is total or partial loss of all sensations, not only pain sensation. Paresthesia is abnormal sensation, the tingling sensation or feeling of pins and needles. Allodynia is pain caused by stimulus that is normally not painful, and hyperalgesia is exaggerated response to mildly painful stimulus. So I hope this terminology is clear. Analgesia, anesthesia, paresthesia, allodynia, and hyperalgesia. Pain intensity measurement is generally quite tough because we're talking about a subjective symptom. And so we must understand that there are various pain scales and each of which have their advantages and disadvantages. But one of the most simplest and most common used is a visual analog scale where the patient is asked to assess or make us, give us an assessment of their own pain scale on a value of 0 to 10. McGill's pain questionnaire has 78 adjectives to describe pain. There are other numerical scales like the multi-axial assessment of pain scale, which has about 61 questions in it. Chronic pain is pain that persists for more than 6 months and persists past its normal time. Generally, chronic pain is related to depression, and chronic pain syndrome is a terminology used for psychological, social, and genetic factors responsible for pain that persists beyond its normal time. Examination and assessment of patient with chronic orofacial pain. It is important to remember that there is no gold standard for diagnosis and no biological markers. That means it is important, it is not possible to assess the presence of chronic orofacial pain with any markers such as blood values or raise in BP or blood pressure or sugar, etc. So, when you are assessing a patient, history, the past, present medical history, review of system, family, social, and occupational history, as well as physical examination, all put together help us in arriving at a diagnosis of a patient with chronic orofacial pain. When we're talking about physical assessment or physical examination, consideration should be given to inspection of the head and neck, skin, swelling, regional anatomy, orofacial asymmetry, palpation of the masticatory muscle, tests for strength and provocation, assessment of range of mandibular movements, palpation of soft tissues including lymph nodes, palpation of TMJ, palpation of the muscles of the neck, cranial nerve examination, general inspection of ears, nose, oropharynx, examination and palpation of intraoral soft tissues, as well as examination of teeth, periodontium, and occlusion. So, all of these put together should be a thorough examination of the head and neck region, inclusive of the intraoral examination, to assess the patient and to conclude that the patient is possibly suffering from orofacial pain. So this is the classification given in the recent classification of the International Classification of Orofacial Pain. It divides the type of pain based on main category and an explanation as to why the patient is having a pain. Number one is orofacial pain attributed to disorders of dentoalveolar and anatomical related structures. This is cases of pain caused by disease, injury, or abnormal functioning of the tooth pulp, periodontium, gingiva, oral mucosa, salivary glands, or jawbone tissues, or pain arising from normal functioning of tooth pulp signaling risk of tooth damage. Number two is myofascial orofacial pain, pain associated or localized to masticatory muscles with or without functional impairment. Temporomandibular joint pain, pain localized to TMJ occurring at rest or during jaw movements or palpation. Orofacial pain attributed to lesion or disease of the cranial nerves is pain that is localized in the distribution of area or one of the sensory cranial nerves, that is trigeminal, glossopharyngeal nerve, with a history of trauma or disease known to cause nerve injury. Orofacial pain resembling presentation of primary headache is generally pain in the orofacial area, resembling one of the primary headache types in pain character, duration, and intensity, with or without the associated symptoms of these headache types, but without concomitant headache itself. Idiopathic orofacial pain is unilateral or bilateral intraoral or facial pain in the distribution of one or more of the branches of trigeminal nerves for which the etiology is unknown. So these idiopathic orofacial pains are something which was termed as atypical facial pain or odontalgia previously. So psychosocial assessment of patients with orofacial pain is also a component of the classification of the orofacial pain. So when we're talking about chronic orofacial pain, first thing would be as a dentist to rule out any dental cause of pain. If yes, then you already know that either it has to be caries, trauma, periodontal disease, or perhaps a cracked tooth. If no, then is it pain lancinating type? That's a very important question. If yes, then you're already looking at trigeminal neuralgia as a possible cause of pain. If it's no, then it's important to consider other types of pain, that is TMJ, sinusitis, migraine, post-herpetic neuralgia, referred pain, or atypical facial pain as a cause of the orofacial pain. So this basic algorithm is important to get started off when you are assessing a patient for possibility of chronic orofacial pain. So, when we're looking at orofacial pain itself, there are various causes or disorders that could be the differential diagnosis for the orofacial pain. So, number one could be intracranial pain disorders, with the differential being either a neoplasm, aneurysm, abscess, hemorrhage, or hematoma, or edema. Primary headache disorders, with the differential being migraine, migraine variants, cluster headache, paroxysmal hemicrania, or cranial arthritis. Neurovascular disorders like keratodynia, tension type headaches. Neurogenic pain disorders like paroxysmal neuralgias, under which you have trigeminal, glossopharyngeal, nervous intermedius, and superior laryngeal neuralgias. Or continuous pain disorders, differentiating neuritis, post-herpetic neuralgia, and sympathetically mediated pain. In the intraoral pain disorders, you could have dental pulp, periodontium, mucogingival tissues, tongue, or burning mouth syndrome as a causative of intraoral pain. Temporomandibular disorders could have a differential of masticatory muscles, TMJ, and associated structures. Associated structures itself, the ears, eyes, nose, paranasal sinuses, throat, lymph nodes, salivary glands, or neck could also be the cause of orofacial pain. So, from what you've understood or analyzed based on this extensive description here, is that there are various causes of orofacial pain, and multiple areas or multiple boxes need to be ticked off to understand the actual cause of the pain in the person. So sometimes it may be very clear cut and easy to understand as due to pain associated from a tooth, but in other situations it's important to differentiate between pain arising from structures that could be leading to orofacial pain in the patient. So this is another interesting algorithm that I have found, which I thought I should share with you. Um, the type and cause of non-dental chronic orofacial pain. Now, this is where the critical area is. If it's dental, like we discussed earlier, it's very clear and easier to differentiate, especially in a dental office. But when the problem comes it when the pain is non-dental and the pain is chronic. So, like we discussed in the previous slide, there could be various causes of non-dental associated chronic orofacial pain. And the word chronic itself is something where the patient is already suffering for more than 6 months, and it is pain that is lasting beyond its usual time. So, if you're talking about musculoskeletal origin, it could be unilateral or bilateral, continuous or episodic, and generally they are temporomandibular disorders or persistent orofacial muscle pains. If you're looking at neuropathic pain, that means arising from the nerve, if they are unilateral and continuous, then you're most likely looking at either post-herpetic neuralgia, post-traumatic trigeminal pain, anesthesia dolorosa, persistent dentoalveolar pain, which is categorized as atypical odontalgia, or referred pain. If they are unilateral and episodic, it could be trigeminal neuralgia, which is a classical or symptomatic type, or trigeminal neuralgia with other concomitant pain, or glossodynial neuralgia. If it is bilateral and continuous, then you may be looking at burning mouth syndrome. So these are the types of neuropathic pain. When you're talking about vascular pain, you're either talking about unilateral or bilateral, generally continuous. It's seen in patients who have post-stroke pain or giant cell arteritis. Primary headaches can be either bilateral, episodic, or continuous, unilateral, episodic, or unilateral, continuous. When we're talking about bilateral, episodic, or continuous, they could either be tension type headaches or medication overuse headache. Unilateral episodic can be trigeminal autonomic cephalgias or episodic migraine. Unilateral continuous could be chronic migraine. Mixed, where it is difficult to assess one particular cause of pain, which could be either bilateral or unilateral and continuous, or persistent idiopathic facial pain or cancer related pain. So, again, this is a complex algorithm, but tried to be simplified the best to understand what all could be the causes and the types of chronic orofacial pain, which is not related to the tooth per se. So let's look at the management of chronic orofacial pain. It's important to understand that it's a multidisciplinary approach. And we start off with education, counseling, and medication. Education of the patient is important to reassure them, and counseling sessions are important because many a times chronic orofacial pain is associated with depression or anxiety. Medication that could be used are simple NSAIDs, and then you move on to add opioids or adjuncts or adjuvants like anticonvulsants, antidepressants. Topical medication like capsaicin and topical NSAIDs may also help. Other pain management techniques could be usage of TENS, which is transcutaneous electric nerve stimulation, nerve block, or acupuncture. Psychological therapy like cognitive and behavioral therapy have also been used, as well as relaxation therapies like biofeedback, mental imagery, yoga, and meditation. All of these together put together help in the management of orofacial pain. Let's look at facial neuralgias in detail. Brief episodes of shooting pain, which is electric shock like along the course of the nerve. This is a very classical symptoms of neuralgia, and this terminology of this is called as paroxysmal. It's a very classical feature of neuralgia where there are brief episodes of shooting pain which comes and goes, and it's electric shock like, and it's along the course of the nerve. So this should be a classical symptom of the patient which should help us identify that we're looking at a neuralgia. Also, patient has trigger zones. That means there are particular areas along the course of the nerve which when touched or are come under pressure or trigger the pain. There are pain free periods between the attacks, and these are called as refractory periods. During these refractory periods, even if you touch the trigger zone, the attack cannot be triggered. On the other hand, a neuropathic pain is constant burning pain without trigger zones, and it is indicating a general disorder of the spinal nerves. For example, if there's a tumor that's pressing on the nerve. So this is important to understand the difference between neuropathic pain and neuralgic pain. So let me just emphasize again. Neuralgic pain is paroxysmal, having trigger zones and has refractory periods. So, trigeminal neuralgia was also called as Stick-Dolerou or Fothergill's disease. Generally seen in patients over 50 years of age. Patient has shooting, stabbing pain, electric shock-like pain which lasts for a few seconds and then they disappear totally. This is called as a tick, that is the episode of pain. Generally unilateral, maxillary division of the trigeminal nerve is more affected than the mandibular, and lastly is the ophthalmic division. Trigger zones are primarily on the skin and the mucosa. It could be intraorally or in the mucosa or on top of the skin, over the skin, generally involving the maxillary and mandibular distribution of the trigeminal nerve. Intraoral triggers can be generally confused with a cracked tooth, and hence it's important that a thorough dental evaluation is done. So this is a distribution of the trigeminal nerve. It's a nerve root as well as the distribution, and hence you can understand that the majority of the maxillary and mandibular division is very close to the dental structures, and hence this pain is easily confused for dental pain. So it could be classified as primary or idiopathic or secondary trigeminal neuralgia. The primary one is more common in females, and secondary one could be secondary to trauma, a CNS lesion like tumor or vascular malformation, or multiple sclerosis causing facial pain, in which it may be bilateral as well. Etiology is generally in a classical trigeminal neuralgia is not associated with any neurological disease, whereas a symptomatic one could be no neurological disorder probably may be detected. In classical trigeminal neuralgia, 10% of the cases, there could be a tumor of the cerebropontine angle, multiple sclerosis, or vascular malformation. Example, a meningioma of the postcranial fossa. In 90% of the cases, there could be atherosclerotic blood vessels, generally the superior cerebellar artery, which is pressing on the root of the trigeminal nerve. This then causes focal demyelination, which causes hyperexcitability of the nerve that fires in response to even light touch. So, this kind of a situation, microvascular decompression could be a good treatment modality. When we're talking about diagnosis of trigeminal neuralgia, it's important to note that on examination, light touch of the trigger zone itself will trigger a severe attack of episodic pain. Electrophysiological testing of trigeminal reflexes can be done, and when a local anesthetic block is given, it temporarily eliminates all the trigger zone. This is again a very classical example of diagnosing trigeminal neuralgia. Also, MRI of the brain and MR angiography are recommended to understand better the nerve and any pathology associated with the nerve or any tumor that is compressing the nerve. Management of trigeminal neuralgia also is quite complex. Generally, medical management is started off first, and the classical drug that is being used is carbamazepine with the trade name of Tegretol. It's effective in 85% of the cases. Generally, slowly increasing doses are given, which start off with 100 to 200 milligrams once daily. Um, of course, this comes with its own set of adverse drug reactions like general erythema multiforme, blood dyscrasias, which can include aplastic anemia or leukopenia, and hyponatremia in cardiovascular patients. A combination therapy with baclofen, oxcarbamazepine, gabapentin, pregbalin, sumatriptan, and phenytoin, all of the drugs can be combined with carbamazepine to manage patients with trigeminal neuralgia. Drugs are generally withdrawn slowly if a patient remains asymptomatic for a period of 3 months. In cases where drug therapy is not effective anymore, surgical management is initiated, and also surgical management is a choice when the side effects cannot be tolerated by the patient. Cryosurgery, which is peripheral portion of the nerve being subjected to cryosurgery, the mental and the infraorbital nerves, as well as effective for only a time of 12 to 18 months. Percutaneous radiofrequency thermocoagulation has also been tried as the Gasserian ganglion, where a glycerol block is given or a balloon microcompression of the ganglion is done. Microvascular decompression is done at the nerve root at the brainstem. 70% of the cases get long-term relief, but 30% may have recurrence. Gamma knife stereotactic surgeries, radiosurgeries, multiple beams of radiation are given at 70 to 90 grade to the nerve root region. So, surgical treatment has best prognosis in typical trigeminal neuralgia early after onset, especially when it is at the peripheral level, ganglion level, or trigeminal root level surgery. Now, moving on to other facial neuralgias, uh, glossopharyngeal neuralgia is the ninth cranial nerve. The pharynx, posterior part of the tongue, ear, infraorbital and retromolar areas are generally the areas innervated by the glossopharyngeal nerve, and these areas could be the trigger factors as well. Nervus intermedius and geniculate neuralgia is cranial nerve 7. This is innervating the ear, anterior part of the tongue, and soft palate. So, trigger zones can be in these areas. Patient, patient could have facial paralysis, which indicates motor nerve involvement, and also could nervous intermedius or geniculate neuralgia could result as a could happen because of a Ramsay-Hunt syndrome, which leads to a neuralgia later on. Occipital neuralgia is the greater or lesser occipital nerve involvement. Generally, the upper cervical spinal nerves are involved, and all of these facial neuralgias also have trigger zones and have typical paroxysmal neuralgic episodes. So the area of distribution is different, and hence they should be considered as just differential diagnosis when patient is exhibiting symptoms of neuralgia. Post-herpetic neuralgia, on the other hand, is slightly different. Generally, patient has an herpes zoster episode and a recurrent infection which follows primary chicken pox. And the herpes zoster is actually caused by the varicella zoster virus, which is a neurotropic virus. The virus remains latent in the ganglion. When the herpetic neuralgia actually happens is when pain is along the nerve and vesicles on the skin appear along the distribution of the nerve. So, but pain may be present before the vesicles erupt. So, this is the classical type of neuralgia that happens when the person is suffering from herpetic episodes, that is herpes zoster. And the neuralgia that happens thereafter lingers along the path of the nerve. Whereas there is a situation called zoster sign herpetae, which means you have herpetic neuralgia without vesicles. Now, in 15 to 20% of cases where patient has had herpes zoster, it involving the trigeminal area or facial or orofacial pain generally resolves in a month's time. But when it doesn't resolve within that month and the pain is persistent, then the term post-herpetic neuralgia is used. So hence post-herpetic neuralgia is persistent neuralgia that continues for more than 3 to 6 months after acute herpes zoster eruption has healed. So I hope you've understood the difference between what is pain during the presence of herpes zoster, and pain after the presence of herpes zoster. That means a neuralgic pain like or pain along the course of the nerves that occurs during the episodes of herpes is called herpetic neuralgia. Whereas the pain or neuralgic pain that occurs after the episode of healing of the vesicles or eruptions is post herpetic neuralgia. So, post herpetic neuralgia, the risk factors would be patients who are older. Example, the patients who get post herpetic neuralgia, two-thirds of them are older than 70 years old. Female patients, and also 25% patients of herpes zoster get post herpetic neuralgia after an episode, after a period of for greater than 1 year. So, the pathophysiology is a combination of peripheral and central nerve injury. The varicella zoster virus injures the peripheral nerves by demyelination. Valerian degeneration takes place and sclerosis. Then central nervous system changes that occur are atrophy of dorsal horn cells in the spinal cord. This leads to persistent chronic burning pain, paresthesia, hyperalgesia, allodynia, and sensory deficit for months to years after the zoster lesions have healed. So that is the pathophysiology of post-herpetic neuralgia. Prevention and management of post-herpetic neuralgia. The prevention would involve getting vaccinated for a varicella zoster vaccine, especially in all patients who are older than 60 years old. Also, patients who've had signs of herpes zoster should be given antivirals early in the course of the disease. So, this has chances of preventing the occurrence of post-herpetic neuralgia. 800 milligrams of acyclovir 5 times a day for 2 weeks. Systemic corticosteroids are also started within 10 days and continued for 3 weeks. Generally, it's prednisolone or subcutaneous infiltration of triamcinolone can also be given in the areas of eruption. So, the role of steroids is to help maintain level of sensory perception and normal excitation of neurons. They also decrease neuronal inflammation and chronic pain incidences. So, the management of post-herpetic neuralgia will involve anesthetics like lignocaine patches or a mixture of eutectic mixture of LA, and analgesics like capsaicin, which can be applied topically. This helps in it's a selective C fiber neurotoxin and depletes substance P. Drugs that have been used are tricyclic antidepressants like amitriptyline, nortriptyline, doxepin, or desipramine, and but they do come with adverse side effects like CNS effects and sedative effects. Gabapentin, pregbalin, carbamazepine, and phenytoin have also been used. Surgical management in cases of postherpetic neuralgia would be nerve block, surgery at peripheral nerve or dorsal root. Moving on to burning mouth syndrome, which is also called as glossodynia. There is oral burning and has no detectable cause. There are no lesions seen and no lab findings. So that is very important to understand that burning mouth syndrome has no visible clinical or lab findings that can be seen in the patient. The etiology has local factors and systemic factors. It could be an allergic disorder or salivary gland hypofunction or chronic low-grade trauma due to parafunctional habits. The systemic factors that have been attributed to etiology of burning symptoms are hormonal disturbances, especially in females postmenopausal, psychological disturbances like such as depression, which is seen in one-third of the cases, and patients who are on drugs like with adverse drug reactions like mm, um, ACE inhibitors like enalapril. So, most commonly, the clinical features involve females who are 10 to 15% of the patients who are mostly postmenopausal, 3 to 12 years after menopause. And the tongue is the most common site, which also involves the lips and the palate. Relieving factors are eating candy and chewing gum or drinking water and beverages. Patient is generally apprehensive, having depression or anxiousness and anorexia. Dysgeusia is also seen. There is abnormal bitter sensation, which is seen in 60% of the cases. Investigations to rule out underlying diseases have to be done. Number one is salivary gland examination imaging, ruling out diabetes, a possibility of diabetic neuropathy leading to symptoms like burning mouth syndrome. Anemia has to be ruled out, as well as vitamin B12 and folate deficiency. So, if you were to look at a management of burning mouth syndrome or differential diagnosis algorithm, it's important to rule out oral causes and systemic causes. Oral causes such as candidiasis, lichen planus, herpetic infection, parafunctional habits, and xerostobia must be ruled out as differential diagnosis. Please kindly remember that burning mouth syndrome itself doesn't have any oral manifestation. So, if any of these are detected and the patient is having a burning sensation, then probably the cause is one of these causes written here. Also, systemic causes could be hematological disorders, nutritional deficiency, Sjogren's syndrome, drug allergy or reaction, or ACE inhibitors. So, all of these have to be ruled out before the patient is categorized as having burning mouth syndrome. But all of these mentioned causes here could lead to burning mouth symptom in a patient. So, the management of burning mouth syndrome, if diagnosed after ruling out all the previous listed causes, is reassurance, counseling, cognitive behavior therapy, and of course, medication. Medication involves tricyclic antidepressants, benzodiazepines, and alpha lipoic acid has been tried, systemic capsaicin capsules have been tried, as well as topical anesthetic and topical clonazepam have been tried. Painful post-traumatic neuropathy. The etiology of this condition is injury to the trigeminal nerve. Generally, the third molar impaction removal causes transient anesthesia or paresthesia of the lingual or the inferior alveolar nerve, which is seen in about 0.3 to 1% of the cases of third molar impaction removal. Implant placement itself could cause injury to the peripheral nerves, and this can be leading to painful post-traumatic neuropathy, removal of a cyst or tumor of the jaw, orthognathic surgeries like genioplasty and osteotomy, post-RCT or endodontic surgery, chronic pain can be seen in 3 to 13% of the cases, and facial trauma. So all of these causes could lead to injury to the trigeminal nerve or peripheral parts of the trigeminal nerve, leading to painful condition. Different types of nerve injuries are classified as neuropraxia and axonotemesis and neurotemesis. Neuropraxia is minor nerve injury where the seep fibers are injured and paresthesia for a few hours to few days results. And axonotemesis, there is degeneration of neural fibers, whereas paresthesia persists for several months. Neurotemesis is nerve sectioning itself, and there is permanent nerve damage causing anesthesia or dysesthesia, which is long standing. Last but not least is atypical odontalgia and atypical facial pain. Now, this terminology has been used sparingly, and it's important to understand that we only arrive at this conclusion or idiopathic orofacial pain also as conclusion or of your diagnosis when you have facial pain that's not fulfilling other criterias. So these patients have chronic facial pain. They have been thoroughly investigated, and they do not fall into any other diagnostic categories. So please be careful when you are diagnosing a patient of atypical odontalgia or atypical facial pain. It means that you have thoroughly investigated the patient and they do not fit into any other criteria, and hence they fall into this criteria. So atypical odontalgia is pain confined to teeth or gingiva, and atypical facial pain is other parts of the face may be involved. Etiology remains unknown. It could be neuropathic as well as psychological in etiology. Generally, female patients who have come to you with constant dull pain and no trigger zones visible. There is phantom tooth pain also present in patient who reports pain that began after extraction or RCT in a region where there is no tooth at all, or the tooth is not having pulp at all, like the one that is treated in RCT, and the patient complains of chronic pain in the area. The terminology is used as that is used is called as phantom tooth pain. So it's often hard to distinguish between pain as a disease and pain as a symptom. So it's important to understand that chronic facial pain is a condition which causes a severe m- disability as well as dysfunction to a lot of patients. Patients actually suffer with pain, and it's important that we don't strike off these patients and give them reassurance and uh, conclude that they are having orofacial pain by doing appropriate investigations and arriving at an appropriate diagnosis. Many a times, if it is beyond our scope of diagnosis, it's important that the patient is referred to the appropriate pain management center or specialist. These are my references, and thank you.